There's actually data that supports that people who have sex 52 times a year, like once a week, live longer than people who don't.
I think there's cardiovascular benefit. I think it's connection.
Yeah.
I think it's movement. I think being able to have sex, right? Sex is a high contact sport. And so, and what I find is there are no age limits to when people, like, you don't ever have to stop having sex. You can at any point stop having sex.
Yeah.
But if it's important to you and your partner, then it should be important to your doctors, and there should be ways to sort of have pleasure. And then also knowing that penetration is not the only pathway to great sex.
Absolutely. And, we've talked about it here on this channel, but like on this podcast about like how you need a certain VO2 max to have sex, right? And so if you don't take care of your health in a multitude of ways, specifically resistance training and cardiovascular training in some shape or form, like at some point it may become physically difficult for you to have sex. And so if that's important to you, that needs to be a part of your lifestyle.
And it's really important that if you have a vagina and you are in menopause age, that things do change. It is a very hormonally sensitive structure. And so without hormones, the tissue gets thin, it gets raw, it gets irritated. And not only is there vaginal dryness, but significant pain with sex. And as so many of your listeners know, it also comes with a lot of urinary problems, frequency, urgency, leakage, and then you can be at very high risk of urinary tract infections. And so using vaginal hormones can be life-saving for anybody of any age, of any history, to really help so sex isn't painful and that you don't get urinary tract infections.
Yeah. And we've said it before, we'll say it again. There is no risk of cancer, blood clots, stroke, really anything untoward with vaginal hormones.
Yeah. So these local low dose vaginal hormones is essentially microdosing. It's super small dose, and it absolutely heals the tissue. It improves lubrication. It changes the pH in the microbiome. And so all the good bacteria can grow and the bad bacteria get suppressed. And it truly is better than Viagra, right? So female Viagra truly exists because it helps with arousal. It helps with orgasm. So this is vaginal estrogen or vaginal DHEA. There's a cream you could do twice a week. There's a suppository you could do twice a week. Vaginal DHEA is every night. So you could choose any of those options. There's even a ring. You could set it and forget it for 3 months. And so this is why we actually helped publish guidelines last year by the American Urologic Association on this issue, which is called genitourinary syndrome of menopause, or GSM. And we have developed all these free trainings on YouTube. We have a whole YouTube channel about it. On our website, we have a whole pocket guide of like, bring a piece of paper to your doctor, say, hey, I want this prescription, which links to all the information. Because actually one of our colleagues just published on this is like Medicare patients with a diagnosis of this problem, 9% get a prescription.
9? That's wild to me because I know you know this, but we prescribe this like candy. Like every woman who is perimenopausal or menopausal and has symptoms, or even doesn't have symptoms but may be worried about getting symptoms, gets offered this in my clinic.
9%. You are a unicorn. You're a magician unicorn. We appreciate you greatly.
That's wild.
Yeah.
That's wild to me. 9%.
So sad.
It really is. It's as if, look, if a man came in with erectile dysfunction, everyone is getting offered Viagra or Cialis. Yeah. But not every woman is getting offered.
Like these 9% with a diagnosis. Like that's what's so depressing, because it's so many people have this problem that are not getting a diagnosis code. And so those with a diagnosis, 9% get a prescription. That's so we crazy. Have so much work to do. This is why we just do not stop yelling.
Yeah, it's so important. So we've talked about exercise and we've talked about hormones. What other like lifestyle, diet changes do you think people need to make to have great sexual desire, arousal, and just sexual function?
I mean, truly, if it's good for your heart, it's good for your genitals. And so anything, the data is a little bit, anytime you have nutrition data, exercise data, it's a little murky. There's been some data on Mediterranean diet. You want to fix sleep apnea, you need to be sleeping. You want to check hormones, testosterone. If you're a woman, you want to consider menopause hormone therapy. We know dopamine is very important. So a lot of medications like antidepressants can hurt sexual health, either lower libido or delay orgasm. And so there are medications that could boost libido. We have 2 FDA-approved medication. One is Addyi, one is Vyleesi, that help with low libido, but also work with other sexual problems. So they help with arousal and orgasm and satisfaction as well. which are great to have in our toolbox. And the other thing that we've published on recently is really devices and erotica. And we as clinicians must get comfortable talking to our patients about devices and erotica because they work. They're fabulous. They're great education tools. And it gives your patients permission and getting them to understand. I think we need to do a better job of bringing in devices into the bedroom and getting everyone on board with it because we wear eyeglasses. We get all sorts of other aids that we need or things that I get in my car to drive. Like I need my phone to check my email. We have
like weighted blankets and weighted eye masks and fancy mattress pads and all sorts of stuff.
We use technology for so many things, right? And so getting comfortable and again, devices, the device industry is so deliciously beautiful now compared to, sort of when we were growing up. And so you can get it on Amazon. You can really find it at CVS today. And again, understanding that vibration can be extremely helpful to access the clitoris and the internal sort of parts of the clitoris. And so it doesn't make you a bad partner. It actually makes you a good partner if you bring in devices into the bedroom. And so we really want to encourage sort of that. We know erotica is very helpful, whether it's reading erotica, listening to erotica, watching erotica. Again, the brain likes fantasy. It likes new things. It likes danger. It likes excitement. It likes to think about things that you maybe would never do. That doesn't mean you want to do them. It means that you like watching or listening or hearing about those types of things. And so just giving that permission, it's funny. I was taking care of a patient the other day. We go to a similar clinic with veterans, and I had this veteran with me, and I was talking with her about this show on HBO that's gone crazy viral called Heated Rivalry. Yes. And I say heated, like HRT is not hormone replacement therapy anymore; it's heated rivalry therapy. And this is a show that went totally crazy viral. It was a Canadian streaming show that got picked up by HBO and is now one of the most watched ever TV shows right now. And it's 6 episodes. It's based off from a book. And it's about these gay hockey players, like these 2 very macho rival hockey players that fall in love and have a lot of erotic moments. And then also this very kind. Have you watched it? It's incredible. Yes. How many times have you watched it?
Just once.
Okay, so you're.
I'm still a newbie.
Apparently, 15% of people have watched it more than 5 times. So people are really into this show. And it's causing all of these heterosexual people to be like, wow. I find watching 2 men have sex extremely pleasurable, erotic. What does that say about me? Or what does that mean for me? And is this good? Is this bad? Why do I like this so much? And it's not just the act of sex, but it's watching their emotions, their feelings, and their relationship. And so I was talking to this patient about it, and she goes, wait, I really like that type of pornography. And I've never said that out loud before. And I thought there was something wrong with me. And I was like, no, there's nothing wrong with you. Like, this is what lots of people like. And you could see her, she just everything kind of relaxed a little bit. And she was so excited to talk to me about it. And I taught her about so it was just, again, the more we normalize and can talk about these things, people feel a lot less sort of alone in this.
Absolutely. I mean, look, it's fantasy. It doesn't mean that you necessarily want to participate. You just want to watch it or you just enjoy it. Like, who cares, right? But yeah, absolutely. I mean, there's so much importance in giving people permission, right? Especially you and I see older patients, particularly veterans, right? And I will talk to them about toys, and sometimes they're like, oh no, they're so shut off to it. But I've also had patients like, well, I've never tried. Which one should I get? What should I do? And I think it's really important. Like I'll tell my male patients, I'll be, you can get vibrating cock rings, right? And that can be great to help you maintain an erection, also be pleasurable for your partner and you. Or if you're having trouble if you're having delayed ejaculation, sometimes these toys can really help. And so I think just realizing yes, it's okay. You're allowed to experiment and try different things.
Absolutely. The clitoris likes vibration. The penis also likes vibration. The perineum likes vibration. And so getting devices for couples and playing with devices and different devices, again, sex is supposed to be fun. It's supposed to be joyful. It's supposed to be adult playtime and playful. And so if you're not talking about it, trying new things, doing, it's going to get a little stale and a little bit maybe lonely. And so this is where I think people tend to go into their own heads or their own spaces and live their own sex lives sort of by themselves because they're afraid of sort of communicating and having these conversations with their partners.
Absolutely. You talked about Viagra. We recently published a paper on looking at Viagra for cardiovascular risk mitigation, or basically reducing cardiovascular risk in postmenopausal women. What did you find?
Well, this was just a wonderful paper that was just recently published in the Journal of Sexual Medicine, where it's more in theory of like, here we know that men who take Viagra Cialis have decreased risk of cardiovascular problems, strokes, heart attacks, actually at least less dementia, which is so fascinating because these are sort of increase blood flow, more than to just your penis, but they increase blood flow and they help with all of these things. Now, we know when you give women Viagra or Cialis, it increases blood flow to their clitoris. They have better arousal. It's just that nobody prescribes this to women because women aren't complaining of arousal problems. Typically, they've got dryness, they've got pain, they have low libido. And so we use a lot of these drugs sort of as an adjunct to these other things that we do. But this paper really looked at, well, why aren't we looking at this for cardiovascular benefit in women? And it's so frustrating because in order to pull off a trial, you need money. And these are generic drugs that, there's not a lot of money in this. And so, and you also have to get your cardiology people to care, which is very hard to do, right? Because as a urologist, it's hard to look at cardiovascular markers. Right. So there's a lot of interest in this and we would love to pull off a study, but we just got to figure out how.
Yeah, I think it's interesting. I've heard this before that women don't complain of arousal issues, but I don't think they have the language to complain about arousal issues. Like they don't really know what that means outside of like, oh, maybe my lubrication is inadequate, which is not all of arousal, right? I think there's more to it and they can't see their arousal, like they can't see an erection of their clitoris necessarily. And so I think they don't really know.
It's a huge problem in sex research because as we say, shit in, shit out, right? If you have bad data that you're working with, you're going to get you're not going to have anything that makes sense. And the way we ask the questions are so bad, and women have with men it's okay, but your erection is different than your orgasm, which is different than your ejaculate, which is different than your libido, and we tend to lump do you have female sexual dysfunction, right? It's sort of like when I go to conferences, listen, I just went to a big conference, Mayo Clinic, and you have a whole panel about different aspects of erectile dysfunction, and then it's like, okay, you get 15 minutes to talk about all of female sexual dysfunction, and you're just you can never get into the weeds because you're still staying so broad, which I'm grateful that I had the opportunity to speak on this. But again, it's so challenging because we've got libido problems, arousal problems, orgasm problems, and then pain. And then there's hormones that play a role in all of it as well.
Absolutely. And I think it is so important to think about all those different things for women listening or for partners who care about their female partners. Figure out try to figure out what you're feeling. Try to articulate it. Don't be afraid to really go in the weeds. Whatever you can say about what you're feeling, because it gives us more information, right? Your doctor may not have the tools, but they certainly can find out. They can look into it and they can ask. And I think the other thing is if a doctor says, oh, go drink a glass of wine or you're okay, the right answer would be, I don't know what to do for you, but I can find someone to refer you to.
I'll give you a perfect example. I had a DM just a couple of days ago from a patient of mine who is a fellow physician, and her husband went to the doctor and he's got some low testosterone, and the primary care doctor says, oh, we got to give you testosterone. And they gave him testosterone at not the dose I would give, but they gave him testosterone. And she says, well, I'm on testosterone. And he scoffs at her and says, there's no data for women on testosterone, and there's no possible reason why you should need that. And he literally doesn't know the data. There's global consensus, by the way, that
Correct.
Testosterone works for women for libido, global consensus. And he's confidently telling this woman who is a doctor, who knows the data, who is benefiting from testosterone, it's been life-changing for her. And he's telling her that there's no data and she shouldn't be taking testosterone while he is prescribing her husband testosterone. I mean, you cannot make this stuff up. So why when it comes to women's health, can you just say this is not my specialty? This is not my area of expertise. How hard is it to say those words?
Yeah. I really don't understand. Like, if you just don't know, like, you are misinformed, right? That doctor is misinformed. Maybe there wasn't data when he was training, right? But there is now, and he's misinformed. It's frustrating. It really, really is. Let's talk about the vulvar vestibule. So I think this is a part of vulvar anatomy that every woman and partner should know about because it's really valuable and important and a cause of pain for a lot of people.
It's so important, and it is so wild how basic anatomy is completely missed on the doctor and the patient, and it gets completely hidden. So we talked about those inner wings, those labia minora. Well, if you spread them to the side like a book, you open them up like a book, then right in front of your face is an oval-shaped strip of tissue that surrounds the urethra, the tube that you pee through, and it surrounds the opening of the vagina, which is the inside part, and that tissue is called the vulvar vestibule. Now, it's very sensitive, hormonally mediated tissue. And so if you think of like the outside of your cheek and the inside of your cheek, they're very close together, but they're very different, right? One is very skin and thick and tough, and the inside of your cheek is very delicate, very sensitive, and, would react differently to different, sort of things. And so the skin of the labia majora and the labia minora are skin, they're tougher. And then this strip of tissue right at the opening is like the inside of your cheek. It's like this very delicate mucosal surface that is essentially the same as the bladder, right? So the bladder turns into the urethra, and then the same tissue surrounds the opening of the vulva and vagina. It's called the vestibule because it's sort of the entrance, like as you then go inside to the vaginal canal. This area is often the reason why people have pain with sex, pain with tampons, UTIs, interstitial cystitis, post-sex pain, things like that. It is often in this tissue. And because this tissue is so sensitive to hormones, as I always say, when you play with hormones, there are consequences, sometimes good, sometimes bad. Things like birth control pills can affect this tissue, breastfeeding, menopause, gender-affirming hormone therapy, surgical menopause, breast cancer therapies that affect hormones. There are so many medicines and things people do, acne medications that can affect testosterone levels because this tissue is very sensitive to both estrogen and testosterone. And also a lot of inflammation can happen on this tissue. And so we see increase in mast cell issues come up in this tissue as well. And so the problem, your doctor often was not taught that this exists, nor were they ever taught how to examine it. It's very easy to examine. By the way, you spread the labia minora open, you take a Q-tip and you poke at the tissue. And if it hurts, you have a problem. It shouldn't hurt. But what do the doctors do is they take a speculum and they put it into the vagina and then they open the speculum and it completely bypasses. So you can't see it. So your doctor will say, oh, everything looks normal. Put the speculum in. Oh, everything looks normal. You're normal. This is all in your head. And that has been going on for decades and decades. Women are told their bodies are normal. It's all in their head, to the point where patients come to see me and they're like, I've been to 10 doctors and no one's been able to figure out why I have pain. And I don't think you're going to be able to find it either. And you get that Q-tip out and you find their pain because they don't have pain everywhere. They just have pain in this part of their body. And they just go like they're in disbelief, right? That you can find their pain.
It is so important. And you mentioned many things that affect it. Another thing that sometimes we see, right, is when women get recurrent yeast infections or recurrent STIs, this can also affect the vestibule.
Yeah, absolutely. It's very sensitive tissue. So any kind of infection can bring inflammation. And then again, sex, we said, is a high contact sport. So if you have something scraping against this tissue, creating like an inflammatory response, it's kind of like people will describe it like sandpaper, like shards of glass, like cutting, burning, stinging, cracking, tearing. These are sort of the words that we get from people. And for some people, they can't have penetrative activities. For some people, they can, but they are going to pay for it later. And for some people, it affects their urinary health. So they got more frequency, urgency. They get constipation. This one's wild. I get patients who can't have sex, but their pelvic floor muscles are so tight, they have horrible constipation. And that's sort of their only sort of symptom. This tissue, again, it's so hormonally sensitive. And so we want to make sure it has optimal hormones, whether it's a vaginal DHEA, a topical estrogen, testosterone. You want to keep it hormonally healthy. If a patient's on birth control pills, we often try to get them to have a hormonal IUD, which doesn't affect hormones as much. And then you also want to look at their pelvic floors. So the muscles underneath can cause pain here. So working with pelvic floor physical therapists, sometimes we'll put Botox in pelvic floor muscles, which can be sort of life-changing for patients. And then, sometimes there's an inflammatory thing that's happening that you have to navigate as well. And very rarely we'll need to do surgery on this part of the body.
Yeah. Yeah. And you've mentioned birth control a few times. So one, you mentioned it earlier when you talked about the labia shrinking, and another when we just talked about the vestibule. So let's talk a little bit how that works and why does it change the hormones?
Yeah. So I love birth control as a concept, right? I love the idea for women having control over their bodies and when they reproduce, and pregnancy is extremely dangerous with high complication rates and people die in childbirth. So I love the idea of contraception. I love vasectomies too. They're a great form of contraception. But again, as I said, when you play with hormones, there are consequences. Sometimes those are very good consequences, like not getting pregnant, and sometimes they're, sort of negative consequences. Everyone who takes oral birth control pills that stop the way they work is they stop the ovary from making its own estrogen, progesterone, and testosterone. And so anyone who takes a birth control pill turns off their ovaries' production of testosterone. And if we believe testosterone is important for the pelvis, the vulva, the clitoris, the libido, which we know the penis is a testosterone-driven organ. We know male libido is affected, male muscle, male bone is affected by testosterone. And so if we think like it just makes logical sense, and we have data too, but like it makes logical sense that it's important for women. And so that's how birth control works. So what you see in the data is mixed here, because again, many people on birth control feel very confident in their sexuality. They feel more in control, so they have better sex life, better sex outcomes. But there is a growing area of research where you see people with lower libido, pain with sex, vulvar complaints, things like that. And I think it's important that we explain these possible side effects to our patients. Now, IUDs don't usually turn off the ovary. And so they can prevent, we like IUDs because they are, set it and forget it, but then also your body is still making its own hormones.
Absolutely. So important. I think so important for people. I talked about this with Erwin too, but I think it's so important that we're not actually counseling women on this. Like I wasn't counseled on it when I got put on birth control when I was younger. I don't think that women are getting the appropriate counseling about how this could affect their hormones.
I think that's where so much of the anger is right now, is people are just like, could you just tell me? Right? You didn't tell me about perimenopause. You didn't tell me about menopause. You didn't tell me about my clitoris and the full anatomy. Every time I've gone viral, it is for that exact reason, where people are like, shit, why didn't I know that? Like, I am a smart, educated, went to college, and I didn't know that, right? Like, and so it's kind of giving those moments of like, hey, I bet you didn't know this about your body. And I think women are just pissed. I think the men are pissed too, because like they want to know what's going on too. Like I can't tell you how cool it is to have a male partner stand behind me and see a vulvar vestibule exam and realize that he's like it's not him, like that she has essentially a sunburn on her vulva that hurts. And so there's this empathy that comes with actually seeing the problem and understanding the problem. And so again, birth control is not good or bad, right or wrong, but like any medicine or anything you do or do not do to your body, there are potential risks and benefits and side effects.
Absolutely. And the thing is, I think that I don't know if it's taught in OBGYN residency, but I don't remember learning this in medical school about oral contraceptives.
So I once got into a screaming match with a urogynecologist in my area when I was a resident, because I was following the data and actually knew what was going on. And he and I were yelling at each other, and he was saying birth control doesn't have side effects. It doesn't have side effects. And it was just like yelling. He doesn't like me very much, but that's okay.
Did you guys love that conversation? Because I know I did. And if you are enjoying this conversation and you've been a longtime listener, I need one favor from you guys. Hit the subscribe button or the follow button on the podcast platform you're listening on right now. This signals to podcast platforms that this podcast is worth listening to and shows it to more people. And it takes just a couple seconds of your time, and it's completely free. Thank you guys so much. And as always, remember to take care of yourself because you're worth it.